So we're being live streamed?
Yes. Okay. And recorded for later, go on our website. So we're joined here by our esteemed panel. We're thankful to Dr. Rick Grusha, who's an associate professor in the Department of Psychology at Washington University's School of Medicine. Brandon Costerison from the National Council on Alcoholism and Drug Abuse. They're the policy coordinator. We also have Mike Colonna, St. Louis attorney, former elected Democrat to the from the city of St. Louis to the Missouri House, and Dr. Mimi Vo on behalf of New Approach Missouri, a position here in St. Louis from Webster Groves. So thank you all for being here. We appreciate it. If we could ask each of our three panelists to maybe give a brief introduction, a few minutes, on the kind of general state of the debate with three amendments and propositions facing Missouri voters come November 6th. Could we get a sense from you of your kind of role in that debate and what voters should know? We start with Mike, you're on the end, so I'll go with first.
I guess the problem is I'm a lawyer, so I'm going to have to ask you to refine your question. So you want to know our role, and then I guess you want to know the bullet points about our proposal, and then kind of the overarching, here's what's going on, was probably going to happen.
Well, if you could give us your part of it and how we fit in the big picture.
Okay. First off, thanks for being here. Mike Colonna. I'm with Missourians for Patient Care. It's the only statutory amendment that's on the ballot. It's known as Proposition C. The way I fit into all of this, I was a Democratic state rep for the city of St. Louis from 2008 to 2016. Right about 2010, I decided to take our medical marijuana bill that had been floating around for 20 years and update it. I carried it for the next 6 years, tried to get it passed, was unsuccessful. And Proposition C is basically the same legislation that I carried in the Missouri House. So that's kind of how I got involved. The folks at Proposition C kind of came together. We're a group of bipartisan people that worked on this back in the day in the General Assembly. We started out by kind of doing a best practices survey of all the different states in the union that have some type of medical marijuana law. We wanted to find out what worked and what didn't work. So we put that together, and again, the final product is Prop C. We're the only statutory amendment, and I think that's significant because, you know, all three of these things are on the ballot. In order to get something on the ballot and change our Constitution or statute, it takes about $1.6 million. So if you take a constitutional amendment, you put it before the people, and it's voted up, and you wrote it wrong, it's going to take at least $1.6 million to fix it. So, you know, the New Approach folks with Constitutional Amendment 2, pretty good proposal. Constitutional Amendment 3, lots of problems. But if either one of those two aren't perfect or aren't right, it's going to be a really hard time to try and fix them. So that's why we decided to file this as a statutory amendment instead of a constitutional amendment. Now, our regulation of this is a little bit different than the other two. We use the Department of Health to issue medical cards. What happens is that a doctor will interview you. They will make a determination whether or not one of your ailments is on the approved list. If it is, then they certify you for treatment for medical marijuana. It's important from our perspective because we actually went out to doctors and asked them, how do you want us to do this? Most people don't know, but Missouri actually has a CBD oil bill, a CBD oil law that was passed 5-6 years ago. For the longest time, doctors wouldn't prescribe CBD oil right here at Washington University. And their complaint was the language in the legislation said prescribe. And they didn't want to do that because they were afraid of malpractice. Fair enough. So looking forward, we try to make sure that that wasn't an issue with this. The Department of Liquor Control would take care of all of the licensing. Significant because, again, looking at best practices from other states that have done this successfully, they treat medical marijuana like they do liquor, a three-tiered system, where you have your growers, you have your distributors, and you have your selling facilities. Sounds a lot like liquor, so we thought Liquor Control kind of has the best hand on regulating a three-tiered system. Let's put medical marijuana under them. We're the lowest taxed. Some people get angry about that. Some people don't. but it's a 2% tax. We cap the administrative fees that we take out of there at 5%. So, if we collect $100, only $5 out of the 100 will go to the state for administrative purposes. The other 95 goes to treatment facilities, education, basically the same pots, veteran services that New Approach or Amendment 2 goes to. We do what's called a seed to sale tracking system. Believe it or not, if you're a grower, when you get a medical marijuana seed, you can put a bar number on it. And you can track that from seed to sale. The idea being we don't want the black market to grow up. We're the only proposition out there that has what we call a local opt-out. What that means is I grasp that my home base of St. Louis City, St. Louis County, Jefferson, and most of the rest of the world do want medical marijuana, but perhaps places like Butler County don't. So if the folks in Butler County don't want medical marijuana in their county commission can put that on the local ballot and put it to a vote of their folks. We also allow for local regulation as far as zoning is concerned. What are the electrical requirements that you'll need, how far away from a school if you want to do that. But we allow local authorities the opportunity and option to regulate whatever's going on in the city or county. And the biggest difference between Missourians for Patient Care and New Approach, other than the constitutional amendment, is that we don't have a home grow included in our proposition. And again, going back to best practices, we touch base with doctors, politicians from other states, regulators from other states, and law enforcement. We thought we'll never be able to get law enforcement to stand down on this, but perhaps we can do something to get law enforcement off our backs so that they don't go out and actively lobby against this. And the one thing time and time again that we heard was, please don't do a home grow. That's just kind of a mask for, black market and illegal sales. So again, it's a bipartisan crew. We have some law enforcement folks that work with us, and we decided to do that. Now, if ours passes and down the road, a home grow wants to be added, it's easy to do. That can be changed statutorily. A complaint that I hear is, well, gosh, the big bad Missouri General Assembly, mock, if your one passes, the big bad General Assembly can come in and change all this and take it away from us. And then they'll talk about the puppy mill law. And for those of you who are new to this region, Missouri put a puppy mill ban on the ballot maybe back in 2010. Passed. In 2011, the General Assembly came in and gutted it. So the fear is if ours passes, the same thing will happen. I suggest to folks, though, that there are big differences between 2010 and 11 and today. If you look at the puppy mill votes, it was basically a rural-urban thing, where a lot of the rural folks, some of them had industries in their counties, but, doggone it, they're my animals, and I want to do with them what I want. A lot of the urban folks, ASPCA, we need to treat pets with kindness. And when you have a legislature dominated by rural folks, they're going to gut something like that. Medical marijuana polls at 70-75% approval rating across the state, whether you're in a rural area or you're in a metro area. So knowing that politicians would like to be reelected, I highly doubt that the Missouri General Assembly would take the medical marijuana right away. With that being said, there are 3 different proposals on the ballot. Amendment 2 is very similar to ours. Amendment 3 has been put forth by a physician lawyer in Springfield, Dr. Brad Bradshaw. It sets up a brand new state department headed by Dr. Bradshaw, with a board appointed by Dr. Bradshaw, taxed at I think 15% on the one end and a lot on the other end. Am I not supposed to talk about this? Oh.
To make sure we get all
the last thing I want to say is I've been asked by a lot of folks at events like this, well, gosh, Mike, what happens if all 3 passes? Well, Missouri Constitution says that whatever initiative petition gets the most votes is the one that will control. The next question is, well, gosh, yours is a statutory amendment, the other 2 are constitutional. So does that mean if your statutory amendment passes, yours is the one that controls? The answer to that question is it depends, and it's a lawyer question. My answer would be yes. The Missouri Constitution, again, says whichever IP gets the most votes is the one that controls. It doesn't say whichever constitutional amendment gets the most votes or whichever statutory. IP. We have 3 IPs, initiative petitions. Whichever one gets the most votes controls. Thank you.
Thank you.
I'm a lawyer politician. I just.
That was a great Missouri sandwich last night.
Hi, everyone. Dr. Mimi Vo. I went to medical school in University of Missouri in Kansas City, and did residency in North Carolina and moved to Texas, and then came back to St. Louis as most people that I know did. We went away and said we won't come back, and then we ended up coming back, and we love St. Louis. I'm glad to be back here. Thank you for all the information about Prop C. I got a chance to read all three, and learn about all three initiatives over the last year, and it's been very interesting. I'm a physician, and I grew up in the 80s, and we were told that this is the wrong thing to do. I saw it in high school, saw it in college, and just remembered my dad is a physician. He was in my ear just saying, that is wrong. And so I would say, hey, that's wrong, what you're doing. But then I got a chance to learn when I was in residency out in North Carolina at a hospice care center that cannabis can be used as a medicine to help people with terminal illness in the last 6 months of their life. And it was helping people to have an appetite and to help with their pain. And it just opened my eyes to the possibility of cannabis as a medicine. And so when I, for the last few months, knowing that this was something that was coming here to Missouri, I just started doing my own education and my own research into it. And I think that Prop C has great wording, and I will vote yes on Prop C. I am here on behalf of New Approach Missouri because going through these different states and getting a chance to see what is happening with medical cannabis being available in 30 other states, and seeing patients being able to get relief from it, and in my own practice over the last few years, hearing from my patients that it is helping them with sleep, helping them with their pain, helping them have a quality of life that they otherwise wouldn't. I am definitely a proponent of it coming here to Missouri and the possibility of having that talk with my patient and being able to recommend or to certify my patient to use medical cannabis. But at the same time, I'm very weary of legislation that doesn't have everything put out. I like the fact that New Approach does protect physicians, and yes, going around and talking to my other colleagues, a lot of them are concerned about this being federally illegal, and will it affect their medical license? Will the Federation of State Medical Boards have an issue with this? And so that's why I joined the Missouri Cannabis Trade Association and am their healthcare and education chair. My focus is to be out there to educate other physicians, to educate nursing staff, to educate physician extenders, as well as patients and as well as the public, to see what research is out there and to see what can be available for our patients, and to know that physicians will be safe in doing so. I hear a lot of different myths from patients and from other physicians as well. They would say to me, well, there isn't enough research. But then I will come back and say, have you looked at the JAMA articles from 2015? Or have you looked at the National Academies of Sciences and Engineering and seen what has been published in the last few years? Correct, we were not taught this in medical school, and 85% of medical schools today still do not teach people about cannabis or the endocannabinoid system because it's federally illegal, but that does not mean that research is not out there. It's just that physicians don't have the time to learn on their own. We are bogged down with 80-hour work weeks during residency, and then we are bogged down with work and paying our school loans and then taking care of patients, and we really do put our lives on the line a lot of times in order to care for our patients. And so to add on a plant that is very complicated, it's very difficult. And so I am here for New Approach Missouri because it is rolled out and spelled out exactly what needs to be done and how it will be done. And I believe that looking at other states where that is not written out completely, it could take years or longer for anything to be done. And as a physician, I do not feel like my patients have time to wait. I have patients who are driving to Colorado to get medicines for themselves, who are telling me about it, and I just have to say, don't tell me, I don't want to know. Or they are having it mailed in from other states. I have patients with cancer who are dying, who I cannot tell them, but likely they will not be around for when this does roll out. And I think waiting a year and a half or 2 years or 5 years is just too long, and I don't want my patients to have to continue to wait. Thank you.
So my name is Brandon Costerison, and I'm the policy coordinator for the National Council on Alcoholism and Drug Abuse of the St. Louis area. We are a public health agency. Our goal is to prevent and reduce the harms associated with alcohol and other drug use. We do this through education, through advocacy, through interventions, and a wide variety of other things. Our goal is to kind of give an outside perspective on these and address these from a public health and perspective. I think that everyone up here and most folks in this room would agree that the ideal solution would be for marijuana to be rescheduled and allow copious amounts of research and medications with known dosages, known potencies, known durations, double-blind studies, all of that type of stuff to be implemented. That would be the ideal solution. However, it doesn't look like that ideal solution is happening anytime in the near future. So our perspective is, if we are to implement a program at the state level, what should that program look like that's focused on public health, it's focused on patient care, and it's not legalization with a copay, basically, like some states have had, but it's really based in evidence and science. So that's kind of the perspective that we're coming at this with. There was a bill in the General Assembly just this past year that would have passed if it wasn't for the supporter, a state senator who's a supporter of one of the initiative petitions. We could have a program today, but a supporter of one of the initiative petitions killed the bill in the Senate. So I don't think it's a question of one of these three or nothing. I think it's a question of one of these three or the potential for something to come out of the General Assembly next year if there are not obstructionist legislators again. That, if there's another IP drive for 2020. I want to be brief so that we can actually get to the questions and discussion points that y'all have, but that's the perspective that we're coming from. Really, what's best for patients and for Missourians.
The funny thing about somebody killing that because they supported their own version, that was the same crew that killed it back in 2014. We would have had this in 2014 if it wasn't for one of the three positions that are on the ballot currently. But we'll let that one be.
What was the primary sticking point for killing it?
They wanted their initiative petition to pass.
Right.
I'll speculate.
What's
You want the real answer?
a substantive difference?
You want the real answer?
Sure.
Money and who gets it.
Ah.
Political consultants who can run an IP, an initiative petition, and make $500,000 versus the General Assembly passing it, and that, in essence, lobbyist or political consultant making $0. That was the issue in 2014, and I'll bet you a nickel it was the issue in 2018.
It's not really which conditions to put
No.
on the bill.
It's greed. Yes, ma'am.
I can take issue with that. The bill that was proposed in the General Assembly was way more restrictive than all three of the initiatives that are on the ballot. So
The 18 bill?
yeah.
Okay, that I'm not as familiar with.
So ours, all three of the initiative petitions that are on the ballot give doctors a whole lot more control over which conditions a patient can try medical cannabis. So there are several other substantive differences. I think also just having it enshrined in the Constitution means that it is not subject to the whims of the legislature or whichever pharmaceutical company or ag interest might be donating to whoever's particular campaign. So only a vote of the people can change the Constitution, and the Missouri legislature is more likely than any other legislative body in the country to overturn a vote of people. So
It is accurate.
I'm going to step in here. We've got about 6 questions to get through, so maybe we can. I suspect the answers to these won't be terribly long. It might be, but I know we've had time at the end. We can kind of go over the pros and cons of each initiative. I know we have the general idea. There's 3 initiatives and one legislature, which is probably more restrictive, but there's pros and cons to that. So
I think for the sake of fairness, we'll allow each of you a chance to answer the question, even if you feel it doesn't necessarily relate.
yeah, exactly. Some of these Yeah, it does. So, question number one from our viewers at home: what conditions do each initiative cover? So each initiative, are they the same, and how do they differ? Actually, let's start
Sure.
with you.
So Amendment 2 does list out, 7 to 8 different conditions, as well as terminal illness, which is global, encompassing various conditions, as well as chronic pain. And this is why I support Amendment 2 wholeheartedly. I've looked at other states. I've seen where this was medically legal in Illinois, but it was restricted to only a handful of conditions, and there were very many patients who really could get relief from it who were not able to. And I've seen in other states where it's it just is not there for patients, and it's not right for physicians and patients who are the ones who should be making this decision in the office.
Just clarification. So on the spectrum of all the programs in the country, would you say Amendment 2 is more restrictive, less restrictive?
Less restrictive. I believe it's less restrictive. I think it's most similar to Colorado or Washington's.
Brandon, do you have anything to say?
I will, but I want to let them talk about what their initiatives say, and then if they want to respond. Well,
Sure.
We have a laundry list similar to New Approaches. A few of the things are HIV treatment, PTSD, chronic pain, cancer, glaucoma. I will tell you that these laundry lists, we'll go out and say ours is a statutory measure, so it's easier to add or subtract to those things. If memory serves me correct, New Approach, the Amendment 2, has a clause saying that different new ones can be added.
Mm-hmm.
So I think that's an escape hatch. Whether or not a lawyer looking to make some money would challenge that down the road, it's speculative.
No, I think that as more research becomes available, then it makes sense to be able to make it broad so that physicians and their patients can decide.
No, I get that. My point is, if you have the constitutional amendment that's passed with a laundry list, and then a clause that says you can add more down the road, there are lawyers out there when we want to add things, they'll think they can make a lot of money by saying, no, you can't add those things. It's not the right thing to do, but I guess like some folks don't trust the General Assembly, I don't trust a lot of my lawyer colleagues.
How does you both talk about this kind of different lists that can be expanded on? Does that then set up a potential for abuse if these things are kind of twisted or tweaked?
that's one of the things that I was going to talk about. First off, I want to mention really quickly the way the structure that Amendment 3 has it. They have a list of certain conditions. I think it's like 7 or 8 conditions. But then this research board that gets created can add conditions to it. Our concern with both Amendment 2 and Prop C is that they do list very specific conditions. And then they say something along the lines of any other chronic, debilitating, or other condition. So other condition that does not have to fall into that chronic category or that debilitating category. And we think that there's the potential for that to open up for abuse, for like in California when somebody gets a medical marijuana card, it's a 25-year-old male, they get a medical marijuana card for suspect glaucoma because one day they may develop glaucoma. So there's the potential for that within the phrasing of both 2 and C.
What I see, though, is that I currently can write for opium products. Opium's a flower, and so is cannabis. And I can use it for anything. Somebody can tell me they have a cold, and I can write codeine cough syrup, and they can become addicted to the codeine cough syrup. Yet cannabis is a flower, where we know the addiction potential is much less, and the rates of people dying from overdose with opiates once a state enacts the medical marijuana law decreases by 25% and by 33% in California. And yet, we see that cannabis can be used to, in one study looking at 400 patients in California, patients were using cannabis to replace their other illicit drugs by 66% or decreasing their amount of alcohol use by 40%. Well, you can give me something, even if they are, using it for chronic debilitating pain, and yet you're telling them maybe you don't have that pain, but they're substituting it for something that won't kill them and aren't going to cause greater addiction and greater problems. And I think that makes sense to me.
I want to move on to the next question, which is related, and it simply says, is there enough research on medical use? And maybe let's expand on that, because I think the answer is, for some conditions, the answer is quite possibly, and for other conditions, the answer is very much up in the air. So, and Brandon, I saw you shaking your head firstly, so we'll start with you.
The answer is it depends. There's very few cut and dry answers when it comes to marijuana. The JAMA study that talks about, so a lot of people will promote marijuana use as an alternative to opioids. The problem is the study that came from established a correlative effect, but not a causal effect, and it didn't account for things like increased access to overdose education and naloxone distribution, and they didn't look at the polysubstance use of both cannabis and opioids. And we know that one of the biggest triggers for a relapse for someone who is in recovery from opioid use is the use of either alcohol or cannabis. So I'm hesitant to take those JAMA numbers with too little of a grain of salt. However, we know that things like chronic nerve pain, it can be helpful for that. We have 2 FDA-approved medications that are derived from cannabis, Epidiolex and Marinol, that are being used to treat a variety of conditions. One of my concerns with Amendment 2 specifically is that it has the potential to prevent people from having access to those FDA-approved medications, because the way they define a marijuana or a product derived from marijuana, and then they state that all of those products must be manufactured in the state of Missouri. Currently, neither Epidiolex nor Marinol are manufactured in the state of Missouri, so there is the potential for one of those lawyers that Mr. Colonna mentioned to try and prevent people from having access to those drugs.
If I may speak on that just really briefly, in the 15 years I practiced as a physician, I have never been able to get Marinol approved. I've never been able to, because it is very expensive. I have to go through a prior authorization process. That process will take me weeks to be able to do that. The medication costs about $1,000 per month. And they have to go through Zofran and Phenergan and Compazine and all these other antiemetics to be able to use it, or even for weight gain. And every time I've tried, I haven't been able to get it approved. And Epidiolex is not available now, but it's going to be used for 2 rare forms of epilepsy. So I don't think that that's going to be a big issue. I have seen a paper that Dr. Addie Wilson-Poe out of Washington University's Medical School, currently doing opioid and cannabis research, that shows that for heroin addiction and people who are going through withdrawal symptoms and relapse, if they used nothing, the chance of relapse was 80%, and she said that with cannabis use, the rate of relapse was 50%. So there was a decreased rate of relapse with cannabis use in patients who are getting off of heroin, and that was control of withdrawal symptoms. And that was
So real quick, what I'd like to do is take what these 2 said and put it in English and what I call street language.
Yeah.
First off, let's be real. There's a federal ban on cannabis research. The feds have designated one university to do that research, and they don't do anything. So hats off and thank you to the folks that are putting themselves out there, putting themselves at risk by conducting this research. Second thing is, I can't stress enough with boiling the doctor's words into street talk here. I should trust this doctor to write a prescription or a recommendation to her patient, period. And I like the laundry list. It's something we have to do, but we should trust you to treat your patient. Secondly, I think both the doctor and lawyers who've been doing criminal law for about 25 years will tell you, marijuana is not a gateway drug. The gateway drug is your dealer sells you marijuana, and your dealer wants to make more money. So he's like, look, I got this little thing. It's called heroin. It's cheaper, and you get a faster high. That's the gateway drug. Marijuana, my experience, those folks that are hooked on opioids and even some worse drugs, if they get hooked on marijuana, first of all, it's not hooked. Secondly, it satisfies those cravings. It's people can function, and it's an alternative tool that we can use.
So the remainder of questions are probably a little more regulatory related, and I know we wanted to get out of here by 4:30 or so. We can certainly go over that. Yeah. So, is there a tax incentive for Missouri voters, and where do the funds go? And I know this is going to be a technical question, and it depends on which
Can I
initiative
just say
passes.
Amendment 3? I'm voting no on 3 because $66 million to fund a cancer research center in Springfield, Missouri is a small drop in the bucket against cancer research. Cancer research is $9 billion a year. It's not going to be $66 million for Missouri. It's not going to be to start a new facility. We have great facilities here at Washington University, at St. Louis University, University of Missouri, who are working to conduct research. So I don't think we should start over. And that's what I say of 3.
So, and just to clarify, Amendment 3 is the
lawyer
proposition for which we
slash
don't have a
position.
representative here, but
Right.
yeah.
And I think they have a 15% tax on what's grown, and then 45% tax on what's sold.
I'm not
I
sure.
think
It's 15%
It's,
on
I
what's
think
grown.
it's 15 at the retail level.
It's
It's
15%.
retail. Okay.
And then a price per ounce.
And they are saying that Missourians are going to get a tax refund.
Yeah, we will.
Glad you brought that up, because it's
I think that's
Okay,
what the
well-
question
well, no,
was.
and going back to the regulatory scheme,
Yeah.
for those folks who are non-native Missourians, we have this little constitutional amendment that was passed back in the early 80s, late 70s called the Hancock Amendment. State politician at the time, I want to become a congressman. The Hancock Amendment is Missouri's budget can't grow by X percentage based upon how much money was collected, the past, whatever. So let's put it in perspective right quick. Expanding Medicaid costs a lot of money. Even if Missouri were to bring in $1 billion of new tax revenue, the Hancock Amendment says Missouri has to give most of that back. Out of the billion, maybe $950 million. So moving forward, talking about the taxing revenue streams that come from any of these that will be passed, it'll be put into the Hancock formula. And yeah, Missourians may get a rebate regardless of which one's passed. But I will tell you that, again, Missourians for Patient Care, we cap the administrative costs, what the state will keep at 5%. I'm not sure what Amendment 2 is. But that goes right back to my original point of, if we get it wrong with the constitutional amendment, it's going to cost at least $1.6 million to change it. And nobody wants to tackle changing the Hancock Amendment because it's popular, but who's going to want to tackle a taxing rate on marijuana at the constitutional level? I just think it's short-sighted. Sorry. For those of you who support Amendment 2 is great, don't get me wrong.
I think the question was more pertaining to Amendment 3 because
Oh.
they have billboards up saying that Missourians are going to get a
They
tax rebate. Yeah, but they're being extremely optimistic about how much revenue this research entity is going to bring into the state. They are likening it to the Mayo Clinic, and I think that with $66 million in seed money, I don't think they're going to get there.
So their idea is that the revenue from cannabis goes to the research center, and then the research center brings in more
all of
revenue.
this revenue,
Oh.
and then ultimately that is going to somehow
Okay.
results in the
Yeah, I'm actually quite curious about how to make research profitable. So if
Yeah, I mean, you might want to give Mr.
yeah,
Bradshaw
all
a
right.
call
I think
because nobody else seems to get it either. But that is what they're
tomorrow
promising.
night with Dr. Bradshaw in office.
So one of the things that we want to look at when we talk about what is an ideal program, in Missouri, we don't tax prescriptions.
Yeah.
And we're of the belief that if it's truly patients who are suffering from chronic debilitating conditions, we should not tax them on accessing their medical marijuana. So Dr. Bradshaw has an effective tax rate of 15% because Amendment 3 prohibits state and local sales tax. Amendment 2 has an effective tax rate, depending on where you live, of between 12 and 14% because it does not preclude state and local sales tax. Prop C has an effective tax rate of between 10 and 12%, depending on where you in an ideal world, if we were to create an ideal program, we wouldn't have excise taxes on top of state and local sales, and we would make it exempt from state and local sales tax. That's one major problem that we have with all three of these pieces of legislation, because if we have people suffering, we should not tax them to plug budget holes.
So, as I understand, though, the taxes primarily cover the regulation.
Yeah, I think we'll
FDA
amend it to
contract
Proposition
is
C. Just want to pay for the additional people that the state would have to hire to regulate the industry.
Correct. I was out to meet Dr. Williams at the Department of Health and Senior Services, and we had this talk. The worry is this gets rolled out. Who is going to be in charge of this? How are they going to hire the extra staff how will they fund that? And that's why New Approach has a 4% tax to help with the regulations. In the initiative, it also says that 30 days after this passes, that whoever is going to apply for a license can go ahead and put in their application money, because that money will help Dr. Williams and the Department of Health to start, because they're going to have to. It will hopefully be merit-based, and they're going to need the money for the licenses, for the platform, for the physicians to certify patients, and all of that.
I'm sorry, that's not accurate. Because both of these say that a lot, Prop C, 5% is kept for oversight. We've already talked about that. That means that 95% of those tax dollars are going for, I think it's education and roads and veterans and all of these things that we need to fund as Missourians. But we're taxing people who are suffering in order to do it.
And roads is Prop B.
Prop B, okay. I know that there's like 5 different, but I think Prop C gets split up into 4 buckets. And Amendment 2, it all goes into this Veterans Healthcare Fund, which, believe me, we want to take care of our veterans. But I don't think that we should be taxing our veterans who are seeking help in order to support our veterans that need help. That math doesn't quite add up.
That's for whatever is extra left over after what's used to get things off the ground.
Okay, so I'm going to actually, this is totally out of left field, and I am not familiar with this case, so I'll throw it out there, and whoever knows the answer can jump in.
If it's a case,
it says, what should voters know regarding the Arizona case where patients may face jail time?
Not familiar with the Arizona case.
Okay.
It's been currently in the news. There is a judge who may try some of these patients and give them jail time because it is still federally illegal, even though they have a valid prescription.
So my question would be, is that a state judge or a federal
It is a
judge?
state judge right now, but if for some patients who might be apprehensive that you guys do all this work to get it approved and that they will still be gone after by...
So from an education/policy perspective, you have to have a lot of people colluding to do that. And what I mean is, Washington University is kind of cool. Part of it's in St. Louis City, part of it's in St. Louis County. The prosecutor in St. Louis City, the person who is in charge of bringing charges against you, has already said that she's not going to issue cases where folks have less than 100 grams of marijuana in possession now. So those cases don't exist in the city. So first, you'd have to have a gung-ho prosecutor that wants to flaunt state law that gives folks who have a medical marijuana card, either under Amendment 2 or Prop C, the right to carry a certain amount of medical marijuana. So if you got a gung-ho prosecutor to file a case, a judge that follows the law should dismiss that case if they have a valid medical marijuana card and it's within the weight limitations and the time varieties that they're supposed to have it. Perhaps you get a trial judge that goes rogue and convicts someone anyway. That's what we have appeals courts and our Supreme Court for. And Missouri's judicial system, most of the time, gets it right.
I do have a quick one. Amendment 2 actually says that the state cannot use state resources, to enforce the federal prohibition on patients that are legally allowed to have medical cannabis. So a state judge in Missouri, if Amendment 2 passes, could not do that. If somebody gets caught on the Arch Grounds, which is a federal park, and if it gets kicked to a federal judge, Representative Colonna would know better than I, but under Amendment 2.
The Arch Grounds anyway.
Under Amendment
So
2,
get a good lawyer, basically.
Amendment 2 doesn't allow you to have it on public parks works anyway.
That's
All
true.
three of them
That's true.
have various immunities.
Right.
2, 3, and C all have immunities for people who are from prosecution for possession, unless they are in a school, in a jail, or I think in a public park, something like that. There's immunities in all three of them. And so unless somebody just goes way off the rails, it's not going to happen.
But I would tell you,
Nor should it.
we don't exist in a vacuum. There are some money interests here that clash, and I will tell you, there are some Federalist Society lawyers. That's the buzz phrase nowadays. Federalist Society lawyers who would look at on the west side of the state, who would look at that constitutional prohibition as a violation of federalism principles. And we don't have a sheriff of Pyro or whatever his name is, but if we did, there are lawyers who would be willing to challenge that and take it up. I know it stinks. We're trying to do the right thing by people, but trying to get the money out of it and egos out of it is just so hard. Both, again, Amendment 2 and Prop C, I think, do a really good job at trying to do that.
So the Federal Society isn't always in favor of states' rights, then?
No, but that's my opinion.
I think we've got one final question that we'll let everybody respond to. And
Yeah, just to get everyone's perspective to kind of maybe put this, or look at a long-term perspective after this election, whether these kind of succeed or not, is that indicative of a longer-term trend in Missouri? Do you foresee these movements as working towards legalization for recreational use, or is there kind of only a push for medical use at this point? Are we seeing kind of an uprising in support that's going to lead to something broader, or is medical use, is that kind of goal achieved from your experiences?
As a physician, just medical is what's most important to me, but as a nation and across the globe, what we're seeing is that it is going more recreational, but as a physician, I'm most excited about being able to use this as medicine. I don't know about you.
Well, if there's what we're trying to do, and that is give doctors another tool in their toolbox.
Right.
But then if you look at polling and trend lines, I'll tell you, I think in 2014 we did some polling that showed about 55% of the public was on board with medical marijuana, maybe 35, 40% with recreational. Today, with medical, again, that's what, 70, 75? And full legalization isn't too far behind. So I think regardless of what we do or Amendment 2 does, you're going to see those trend lines continue to move towards legalization. And that's just something that Missouri will have to cross when that issue is put in front of them. But today, again, we're just talking about giving doctors another tool in the toolbox.
Yeah, so there has been just very brief legislative history and what's already on the horizon. So there have been full legalization bills introduced the past couple of years. I know you would have an idea on how long those have been being introduced, but I know that there were at least 2 full legalization bills introduced. There was a city ordinance for the city of St. Louis that was proposed that was kind of full legalization, but in a really weird way. And there is a specific marijuana lobbyist in Jeff City who has said that we should anticipate seeing he wants to see full legalization by 2020. So I think that is a very ambitious claim to make, but I wouldn't doubt that there's at least bills getting a hearing and making it out of at least one chamber. And one of the people who sponsored a full legalization bill is the same person who obstructed the legislation in the General Assembly this year, and if it was the same person in 2014, and he was the one that is supporting the full legalization. So I would anticipate that we'll see that sooner rather than later.
But I think that, in all fairness, I think that's something that you see all the time. Does it get passed? No. Perhaps the new approach folks have better statistics on this, but most, if not all, of full legalizations in states have been citizen-driven, bypassing the legislature with a citizen initiative petition, putting it on the ballot. So I don't see our conservative General Assembly doing anything like that in the near future, but I could see your neighbors, your friends and your family moving in that direction, putting some money together and doing that down the road. But that's about $1.6 million in today's money. It will probably be more by then.
Okay, I think we're
Do you-
about.
If you guys have a little bit, do you have any more questions? I can stay for a minute or two.
Yeah, I can stay till 5.
I have a question. How did what was the process for determining the list of conditions to put on the bills?
I think that has to do with some of the research that we have already available. I know JAMA went and did a meta-analysis looking at 28 different good quality research studies
The
and
whiting,
compiled.
the white paper,
No,
the 2015 white paper.
this is a meta-analysis. I'm not sure if it's a white
Okay.
paper. I know there were a few different papers in 2015 that came out of JAMA, but I think looking at that, looking at other evidence-based medical research that's available. I know I reviewed the 2017 National Academies of Medicine, Science, and Engineering yesterday, and I looked at that. And so I believe that it really, I didn't write it, I haven't been with New Approach, but as far as being an advocate as a physician, but I believe that it's been looking at these different research papers and going through it.
Our laundry list partially came from, again, a survey of best practices across the country, but there were some full-blown hearings on medical marijuana in 14, 15, and 16, where folks like the orthopedic or the Cardinals and the Rams would come in and talk about, well, in my experience as a doctor, here's what I would say would be a good, what would be a qualifying condition to recommend medical marijuana for. I will also tell you that the Missourians for Patient Care folks and the New Approach folks have kind of sat back and realized that we're the two best choices. So we hope one of us gets the most votes. Let's start talking now about how to harmonize the two so that if we've got some shortcomings or they've got some shortcomings, there's a way to take the best of both of them and actually put it into a regulatory practice.
And I think that, California has had medical cannabis law since 1996, so this is something that's been going on for 20 years, and so we've had 20 years of being able to look at what other states have done, 30 other states have done, so I think that that's where New Approach and, you guys probably had a chance to look at all that too. But yeah, yes on 2, yes on prophecy, no on 3. Yes on 2, no on 3, yes on prophecy.
What did the doctor say?
I had nothing to do with the list of conditions.
All right.
Any other questions? Either submitted
I
or
have another question.
How do you guys feel about time? I've got 3 questions that haven't been.
Yeah.
Okay, so I guess we're extending this. So this is, I think, how will you set up dispensaries and regulate distribution, and what legal penalties are there for misuse? I would guess the legal penalties for misuse would just fall under criminal statutes, but.
Can you say the question one more time?
How will you set up dispensaries and regulate distribution, and then what are the penalties for misuse?
And the New Approach has, in the initiative, I believe it's 192 dispensaries, and that's 24 dispensaries per congressional district. So it does try to spread that across the state, is what I understand.
Cheat sheet.
I'm texting my colleague, how many dispensaries? Our dispensaries are based upon population. E-N-C-E-R-I-N-S.
Yeah, I want to say that y'all's are like 1 per 30. No, I thought it was like 1 per 35 or 37,000. Pretty much 1 per house district statewide.
We also allow for a lot of local regulation, and unless, generically speaking, unless a facility is selling medical marijuana on the table on the black market, any penalties, any violations of regulations would be civil or administrative charges, not criminal charges.
And I think that, being, working in the rural area, I really do hope that this will be spread out throughout the state. What I'm worried about with letting local municipalities make decisions is seeing what has happened in California, where there are certain local municipalities where there's, where you're allowed to, and then other ones that you aren't, and it just makes it very messy. It feels like it feels like patients have to then drive here or there and not be able to just get it locally where they're at. Although I think that the seat to sale tracking, I've seen that in other states, and I think that that's wonderful to be able to have a barcode for the plant and then to carry that on so that we know if there is any adverse effects, we can track it all the way back to that plant. I think that makes complete sense. I think that having lab testing, I really would like to see that happen in the state of Missouri so that we are making sure that the medicine we're giving patients don't have pesticides or molds, and we know what percentage of CBD, what percentage of THC, CBN, CBG, all these other cannabidiols that we're just learning about, because it's not just THC, folks. There's like 100 different cannabidiols, and we're only starting to research it and be able to understand that and the terpenes and the flavonoids. And so I think that that's going to be important for Missouri. That seed-to-sale tracking, regulating it, keeping it from the underground market, being able to have a variety of choices because it's not just one type of plant. There's different things that we can use it for in different ways.
So both the properties both have seed-to-sale tracking.
That's something you guys do.
Yeah, they both do. I want to take a step back and we think that dispensaries, they should be available in communities that need them. I worry about putting 24 per congressional district. In some places, that's more than their Starbucks. I can imagine 24 dispensaries in the city of St. Louis, or the Clay district. That's a lot, very, very concentrated. So that's a little bit concerning. But we also want to make sure that in Butler County, if there's sufficient patients to meet demand, that patients are able to access care. We think that known potency, known content is very important, and that's one of the reasons that we get a little bit uneasy about raw botanicals, because one plant to the next can have a wide variety, and so what we're talking about is on average dosage, not necessarily, you eat this one brownie, we know you're going to get this much of this content. But when it comes down to and one other regulatory thing that none of the initiatives have that would be pretty essential to stopping a black market flow would be inclusion in the developing PDMP or some form of a PDMP to prevent someone from hopping from one dispensary to the next. Now that might be something that comes out of DHSS regulation, but there's nothing in any of the pieces of legislation that prevents someone from taking their registration and going to multiple dispensaries. But when it comes down to an individual who might have more or an excess of marijuana than they're allowed to, or even when it comes to someone who's using it recreationally, we take issue with arresting and incarcerating someone for the possession of a drug. Folks that are in that situation typically need help, and incarcerating them is not getting them that help that they need. So we really need, Missouri as a whole needs to take a major turn in the way that it looks at substance use in general, not just punishing people for the possession of the substance.
Two quick updates. Update number one. One license per 100,000 is correct, but one license will allow you to operate 3 dispensaries. So that's a lot more in St. Louis City.
So that's 60.
That's a whole lot.
That's 90 then.
So,
There's 6 million.
math was not my strong point. That's why I became a lawyer.
60 times 3, 90.
Well, the city of St. Louis is 300,000 people. So it's 3 licenses.
Which 9.
It'll be 9
And I think that makes complete sense. What I'm worried about is something like Florida, where there's 6 for the whole state of Florida, and that concerns me. But I think that makes sense.
So in fact, in 2016, 2017, we did a complete criminal code rewrite. And folks on the street know this, but I'm not sure it filters down to the ivory tower of education. In Missouri, we basically decriminalized misdemeanor marijuana. So it used to be 35 grams, I think it's 40 grams per misdemeanor possession. If you do get a misdemeanor possession charge, there's no jail time. It's just a fine. Don't be fooled. If you just pay a fine, you still take the conviction. But in most jurisdictions, you hire a lawyer, you can still make that go away. But with misdemeanor possession, there's no jail time anymore.
Still take issue with that.
Right?
So decriminalization would mean that
Decriminalization would mean it's not a crime anymore.
But it's misdemeanor, so it's not decriminalized. So you.
Right. So if you just paid your fine and pled guilty, you'd have to say you pled guilty to a misdemeanor.
The city of St. Louis, in contrast.
The city of St. Louis refuses to charge those cases. Now, here's a little fun fact for you. Sorry, my street's coming out of me here. In St. Louis County, the prosecutor who's on his way out, which is Bob McCullough, who's been a prosecutor forever, he has refused to issue misdemeanor marijuana cases. So what has happened in our ridiculously complex cash cow of a court system in St. Louis County is your municipalities will take those cases and run with them. You know, the city of Overland Park will charge you with in essence, misdemeanor possession and get their money out of it. But at the state level, well, St. Louis City and County don't issue those cases. I can't see the new prosecutor, Wesley Bell, coming in and changing that policy. In fact, I think he may lean more towards the policy that Kim Gardner has instituted with possession under 100 grams.
I think some clarification is an area of interest of mine. So McCullough wouldn't prosecute the cases, but would turn them over to the municipality. Is that what?
So it's jump into English here. Officer writes you a ticket for misdemeanor possession. That ticket would go to the prosecutor's office, Bob McCullough's office.
Yeah.
He has prosecutorial discretion. Any state prosecutor does, whether or not to actually issue that case. When it comes to misdemeanor possession in St. Louis County at the state level, unless there's something else going on, you know, like a burglary or a crime of violence, Bob McCullough would say, I'm not going to issue a case against them. So the law then says that it rolls downhill to the next court of jurisdiction, which would be, well, let's say it was a St. Louis County cop that wrote it, which would be the municipal court of St. Louis County. So if Bob McCullough would refuse to issue that, then the officer would take that ticket to the St. Louis County municipal prosecutor.
Okay.
And 9 times out of 10, they issue that because that's an easy amendment and $500.
Got it. Okay.
Which is what Senate Bill 5 tried to fix a few years ago, but that's beside the point.
Let's see. So, it's really only one or two other questions, and one of them relates to how states' medical marijuana laws have been used as a template for these initiatives. It sounds like they most definitely have in all cases.
Aside from Amendment 3, which
Okay.
is kind of out of thin air, or other places.
We have these conversations off the grid, of course, and I still believe that anybody that's involved with this, even push comes to shove, sure, there's a lot of money involved, but they're doing it for the right reasons. And I do believe sometimes egos get in the way, and some folks figure that their reasons are the righteous, and that they are the only ones that can do it correctly. But I don't question anyone's impetus on trying to get doctors in another tool in their toolbox to help people with their addictions and to help people with their chronic illnesses. Even Amendment 3.
So, one last one.
Yeah, one last question. Have you thought about potencies and ratios and concentrations of different cannabinoids? Like, have you thought about a minimum CBD and a maximum THC?
So, I think that it's going to probably end up being the dispensary to help figure that out, and then the laboratory that's going to be created. I am focusing on educating the public when this goes forward, to maybe put a brochure, which I'd love to be able to do, is put a brochure in the different dispensaries that would say, start with 2.5 milligrams if you've never tried this before, start slow, go slow, and these are the different forms, and this is what we need to do. I don't think then the regulation is going to have that. I think it'll end up being the dispensaries and the different businesses who end up coming here. But that out in other states where I've seen this, there's a wide variety. So there's a huge variety of different products and different percentages.
To echo what the doctor's saying, I will tell you that if none of you have been to a dispensary, the folks that work there get a ton of training on those issues. Where if you have somebody that just walks in with a new card and they've never tried medical marijuana.
What kind of training?
I would call it industry training.
It is, but there are sites out there. There's a company called Hemp Staff that does dispensary training. There are different ones that dispensary owners will use, because I've looked at these different states and looked at what they've enacted from the medical standpoint, from a physician standpoint, to see what their departments of health are doing. And I think that there are going to be coming out different places. I know there was a website that I found was very good for patient education called healer.com. So I did the training myself and tried to learn and understand from a patient's perspective. But I think that you're going to find, as industry matures and goes forward and gains experience. There are going to be dispensaries who will say, "Hey, my dispensary has dispensary agents who are, trained, and this is where we got our certification."
And part of where you're going, and I'm glad you brought it up, because it's the whole, from my perspective, folks that want these licenses, that want to operate a dispensary, need to do it the right way. That means they hire good lawyers to help them do it the right way. Part of helping them do it the right way are educating folks on things like the following. We know that Missouri has a DWI law. It's .08, and you got a DWI. We also have, under the same statute, in essence, a DUI law, driving under the influence of some type of a drug that impairs your driving. When it comes to marijuana, there's nothing in statute that says this per milliliter. When it comes to prescription narcotics and driving impaired on prescription narcotics, there's no designation in state statute that says, again, what X amount per milliliter of blood it has to be. So, what I think folks that operate dispensaries in Missouri and other states come to find out is if you have somebody that walks in, they're a brand new customer, and part of the industry, the regulations are, you know who your customers are. You know whether or not they've been there before. You don't throw a high potent medical marijuana at them. You start them off slow, because their lawyers are going to tell them if that person walks out your door, they hop in their car, they smoke a high potency medical marijuana, they get in an accident, you're going to get sued, because there's no protection against you anywhere in statute that says you should be protected. So, again, is this spelled out in regulations anywhere that this is what you should do? No. But I think
Patient education, physician education, industry education, it's going to be, it really will be education. You've probably seen that with educating the public.
Yeah, so we do work a lot on educating the public, and this is also where we get into what would an ideal program look like, and that's why we definitely have some hesitations with all three of these initiatives. So none of them have limits on how high potency the THC can be. In Colorado and other places, we see dabs and waxes getting up into the 70s, 80s. I think there's even one in the 90% THC content. And some people ostensibly use it for medical. I don't think that high potency is necessarily being used for medical, but maybe it is. I'm not a doctor. I don't know. But one of the other things that is kind of concerning is the education component that we talk about. It's great for dispensary staff to have education. Only one of the IPs, and I don't remember which one, so I don't want to say for sure, but only one of them requires that a pharmacist be on call for the dispensary staff. I think it's Amendment 3, but I could be wrong on that. So you're hoping that the dispensary staff is trained. So in Missouri, we require more education, at least at the county level, for people who serve alcohol than for people who would be dispensing these drugs.
in Missouri we require hair braiders to have more education.
So your hair braider is going to have more education than the person dispensing your medical marijuana. Yeah. So if we're relying on these folks to be you don't know who you're going to get, especially at the beginning. Now, I'm sure as time goes on, there will be more refinement, and word of mouth will say these people know what they're talking about, and these people don't. But when people are suffering from major medical conditions, I don't want them to be guinea pigs. So that should be something that's in there from the get-go. And a strong IP or a strong regulatory, something that Amendment C would allow, Prop C would allow, would be for the General Assembly to come in and add that requirement. Both 2 and 3 place restrictions on what the General Assembly can do to further regulate. That's concerning. So that's kind of where we see a lot of the questions that you just asked about.
But Health and Human Services can add that requirement.
So long as it's not seen as a burdensome regulation, right, which is not defined. And if I say that, if I have to put my people through a 5-hour training, well, that's burdensome on me.
But this is almost don't let the perfect be the enemy of the good. Let's give doctors.
There is flexibility with what HHF.
I think that we should do that. I think that it should just be a better bill than any of these IPs. Now, 1554 last year wasn't perfect. I won't contend that it was. I think that there were some problems with it, and that's why we never came out in support of it. But I think that we can get something better passed next year if we don't have a obstruction in the General Assembly.
I need to supplement and slightly correct one of my previous comments regarding our 2014 scenario where we didn't pass it. There was a strong lobby of folks that felt that the bill we were about to pass was too restrictive. And the belief that with a little bit of time, we could get a better piece of legislation put together before people. So, I still distrust folks and think greed plays a role, but there are also those people, again, who are out there for the right reasons, who felt that it just wasn't time in Missouri yet because we hadn't advanced to the level where we could offer the service and product that needed to be offered.
The only reason the legislative bill got as far as it did was because they knew that there were initiative petitions collecting signatures to put it on the ballot, and they wanted to preempt the voters. And it still didn't get there. There was no way that worked.
History, because the rest of the history was the initiative petition that was there were folks out working on it, and yeah, your bill isn't good enough, we're going to do it with the IP. So they went ahead and they put it on the ballot, and they got sued, and they got taken off the ballot, and then we were put 2 more years behind. But it's just history, I'm sorry.
And if
bad lawyers.
if you were to be in my office today, seeing my 45-year-old Vietnamese patient with stage 4 breast cancer who's flying to California every 2 months, and her breast is completely destroyed, and you can see it on the skin of the breast. And for her to tell me she's going to California every 2 months to get medicine for herself, to get cannabis for herself, and to get her chemotherapy and her treatment, and you wouldn't say, let's wait 1 more year, let's wait for another initiative because she may not have that year. And then for the whatever time it takes for that to be hashed out after that passes.
And Doctor, thank you for keeping this real.
No, it is.
You're right. Yes, you're right.
And it's multiple times a day that I see things like this, not just one.
Well, I think that about wraps it up.
Yep.
Thank you so much.
Again.
Thank you for allowing us this opportunity.
And